Welcome to Methodist DeBakey Heart and Vascular Center Grand Rounds. It is a distinct pleasure for me to have our speaker today, Dr. Doug Packer from Mayo Clinic. He is absolute leader in the field. In electrophysiology, he is a professor of cardiology and electrophysiology at Mayo Clinic. And he has had many awards throughout his career, including ACC Distinguished Scientist Award. He is the principal investigator of the most important clinical trial in atrial fibrillation ablation to date. And not only he has achieved pretty much everything in his career and has reached the top of our profession, but he's genuinely a nice guy and very approachable and someone that cares that junior people make it and helps out. And I can attest to his leadership and mentorship in that regard. He's going to be talking to us about the prognostic benefit of atrial fibrillation ablation, insights from the Cabana trial. You can access the questions through the web and by text. I think you got those instructions there. And then we'll have questions at the end. Without further ado, Doug.
Well, thank you very much. It's good to see you in particular. I have to say I don't see the rest of the audience, and I appreciate them wherever they are hunkered down by their computers. I wish I could come down there and be with you in person, but I think that we're all having the same issues with COVID. But the good news is we get to talk by Zoom, and I think that there are a number of things about Cabana that I want to share with you over the next half hour or so. So you've already heard the title. The thing that I need to do is I need to give you an idea about my disclosures. Some of them have to do with advisory boards, but I don't receive any money at all from advisory boards. The next section is grants. And Cabana was funded by 4 NIH grants and some industry contribution. And then there's some intellectual property that we have that has nothing to do with what I'm going to be talking about. The other thing is that I don't think I'm going to say anything off-label. I think that it's all pretty straightforward. So let's go. So this is the Cabana trial, and it's the catheter ablation versus antiarrhythmic drug therapy in atrial fibrillation. And Miguel knows all about this. He's also one of the world leaders, and he's also been busy in clinical trials. And so he knows the ins and outs of these sorts of things. And now I'm going to show you. So there are 2,200 patients that are enrolled in Cabana, half ablated, half drug therapy. We actually ablated 90%. You could say, so why didn't you ablate everybody? And the answer is that there were about 9% that were not ablated because of cost, really. Or some people changed their mind, but in China, there are a lot of people that just couldn't do it. We had to redo 19%. That's pretty low for redo ablations. And we completed 48 months of follow-up in about 90% of the patients. Now, on the drug side, everything is pretty much the same, except there are 301 patients, 27%, it's what we predicted, crossed over to ablative therapy. And that created a little bit of a problem. And if you look at this, there were a lot of tweets and twits and I think mostly twits and people who said, well, you know, this is a negative trial and we're not sure what to make of it. And so today I'm going to tell you that it's not a negative trial. It's neutral in some places and it's very positive in others. And this is from Princess Bride. My name is Indigo Montoya. You peeled my father, prepare to fry. So there were some of these kinds of fights that went on early on, and now that we've got the rest of the data out, this has pretty well gone away. So demographics, just to tell you that there were about 34% that were less than 65 years of age. There were between 65 and 75 years of age, about 52%. And there were 14% that were greater than 75. 37% were women. And then there were 10% that were minorities. Now, in paroxysmal, 44% were paroxysmal. The rest were persistent or long-standing persistent. And they were pretty highly symptomatic. They were class 3s and 4s by the Canadian scoring. And they had been in the hospital before. but the overall prevalence of new patients was, most of these patients had had atrial fibrillation for no longer than about 1 year, and most of them were about the 6-month mark. Now, look at the primary endpoint. Here you're looking at, and a lot of the slides I'll show you, blue is the drug group, and kind of this funny orange. I don't know how we got orange. It's almost Halloween, and so go with it. But if you look at it, in general, there were fewer events in terms of death, disabling stroke, serious bleeding, or cardiac arrest in the ablation group than the drug group, but the hazard ratio was only 0.86, and it crossed over. So we have to call this at least a negative trial or a neutral trial for that. But if you look at the primary endpoint subgroup analysis by intention to treat, you find that most everything is on the line or neutral, and the hazard ratios or the relative risk reduction, for the most part, is on the side of ablation. Now, if you're under the age of 65, if you're a minority, and if you have class 2 or 3 heart failure, for the most part, then it's a very positive trial. Now, if you go by treatment received, and that's, some people will accept this and some people won't, but treatment received basically says if you were ablated, 7% had the primary outcome, 10% or 11% of drug patients did. The hazard ratio was 0.67, and there's about a 33% relative risk reduction, and that was highly significant. Same thing was true with all-cause mortality. Same thing was true with death or cardiovascular hospitalization. Now, it turns out that this was true no matter whether you used intention to treat or not. Now, if you look at the comparators or the KM curves, then there is a more substantial difference as you get out. Things started to split about 12 months. Hazard ratio 0.73, or the point estimate, and the confidence interval is 0.99. So one of the things we wanted to do early on, after looking at those confidence intervals and what the trial looked like from its neutrality, is does it apply to anybody? So Peter Noseworthy did a paper that came out at the same time and looked at Cabana patients who were ablated or who were drug treated, and he went to Optum Labs and got about 200,000 patients. And the question first was, well, do the trial participants in Cabana represent the real world? Because there are people that were blogging and saying, well, this is not the real world. But the answer is, it is the real world, because the centers that we chose had experience, but they weren't the best university centers. And Miguel, you'll understand this. The problem was the very, very best university centers were the ones that enrolled the least. And that's always an entertaining thing. But if you go on, you want to know whether you can interpret it in terms of what the treatment effect is and what happens with an excluded population. So we did a propensity scoring or matching overlap weighting to balance patients with, and we looked at 90 different characteristics. And so there's about overall 183,000 patients, and we use the same kinds of analyses that we did with Cabana. Ablated 12,000, drug treated 171,000. And you can see we looked at demographics, characteristics, medical history, concurrent medical therapy, and then the Cabana outcomes. The bottom line was, here's Cabana, where it was neutral on face, except for per protocol, where the point estimate's about 0.27 down. If you look at the Optum trial, where there's 135,000 eligible patients, it's about the same. It's 0.70. But the difference in absolute and relative difference in overall event rates is substantially greater. So it turns out that Cabana is not just for universities. Cabana is for the real world, and it works in about 75% of the population. In 5 to 10% of the population, the ones that didn't get enrolled would not have been enrolled anywhere else either. So the treatment received 0.67, And then there's a larger risk to absolute risk reduction in practice versus the randomized clinical trial. Now, this is something that any of you who have done clinical trials know, that when you're doing a trial design and trying to execute it, you know, there's the strict approach, there's the purist approach. You do an intention to treat, and it's existential. Well, that's what we did. We said we would do that, but we also pre-specified that we would look at per protocol and we would look at on-treatment analysis. That's a little bit more of a pragmatic or practical approach. That's what you and I do when we take care of patients who have atrial fibrillation. And we feel very strongly that Cabana, the data are explanatory. They're not exploratory. This is not a matter where it's just a matter of potential trials in the future. It's what's here and now, also in the real world. So let's look at data that you maybe haven't seen, because these are new patients, new studies. This is a paper that came out from Gene Pool, AF Recurrence. So if you look at the first recurrence, or if you look at freedom from recurrence, there are about 60, 67% of patients who are ablated that did not have any recurrence. On the other hand, there's about 35% of patients who were treated with drugs who did have a recurrence. So regardless of what you say about the intention to treat and the primary endpoints, Cabana was very, very different if you were ablated than if you were drug treated. Same thing with paroxysmal versus persistent and long-standing persistent. If you look at burden, the burden was much less in patients who were ablated, whether they were paroxysmal or whether they were persistent. And so Gene did a very nice job, but it says what we need to know from applying these data. Is it worth doing an ablation from the standpoint of AF burden and recurrences? Absolutely. More importantly is quality of life. And Dan Mark put this paper out. And if you look at MAFC scoring by intention to treat, and this is adjusted mean differences for ablation minus drug treatment, you start at 3 months, you go all the way down to 6 months, or 60 months, 3 months to 60 months, because we had follow-up in about 40%, 50% of patients all the way out to 60 months. And in all cases, that favored ablation, so the quality of life is better. Age. Well, nobody down there is over 50. So does this apply to the people who are watching this because you're all under 50? Well, I'm a little bit over 50, so maybe age makes a difference. And let's look. If you're under 65 years by intention to treat, and this was a pre-specified analysis, patients who were ablated had fewer event rates than those that were drug treated. 65 to 75, more or less the same. In the middle, it's significantly different here, but across the board, it's not. But if you get up to over 75 years of age, as far as the primary endpoint, no difference to begin with. And then drug patients will do better, and the event rates will be higher. And if you look at the interaction p-values that are adjusted for all of the confounding variables that you would expect, it's 0.07, which is what you'd expect for something like this. There are differences here, differences in a different direction there. AF type. So this was put together by Christy Monahan, and I only want to show you down here that there's about 470 patients that were paroxysmal, 524 that were persistent, and about 114 that were long-standing persistent in ablation. No difference in that distribution in those who were treated with drugs. And if you look at paroxysmals and persistence, there were many more recurrences in drug-treated patients than there were in ablation patients. Over here, for the first 36 months, ablation patients did better. But as you got over to 48 and 60 months, then the hazard ratio came together. Overall, it's 0.64. Overall, it favors ablation, even in long-standing persistent, but not if you've had atrial fibrillation out 48 months. How about heart failure? So, Miguel, this is the one that by far and away was the most surprising to us. Even though Castle AF had been out and LIAC and Camera and ARC and other studies, those studies had their problems with statistical analyses and had their problems with the fact that there are like only 170, 200 patients that were in those trials compared to here 2,200 patients. But if you look in patients that had heart failure versus the ones that weren't, and these are all the patients with heart failure, the patients who were ablated did much better with a lower event rate than the patients who were drug treated. So that's in heart failure. So that's, again, a little bit surprising. This was pre-specified and is by intention to treat. Recurrence rates were lower amongst patients with heart failure than if you're ablated than if you were drug treated. And if you look at the quality of life, it looks almost identical to all of the patients. So the patients who had heart failure had adjusted mean differences in ablation minus drug therapy, which is the way Denmark would score this, in all patients from 3 months out to 60 months. It all favored for quality of life. It favored catheter ablation patients. Let's keep going. So a paper is going to come out pretty shortly on minorities and ethnicity. So what do you think? Well, for the primary endpoint and for the secondary, for the mortality benefit, patients who were minorities had far fewer event rates than patients who were drug treated. So ablation, drug treatment, far fewer events in those that were ablated. And if you look at it where you get it all together, so now here we've got minorities, non-minorities, we've got heart failure, non-heart failure. If you look at ablated patients in minorities, they did the best in terms of lowest recurrence. In ablation and drug, minority, non-minority, not much difference if you put them together. And then if you made a comparison with those who had drug treatment, they had a much higher event rate. Hazard ratio, minorities, point estimate, 0.33. And this is way away from the line of unity. Now let's go a little bit further. Let's talk about North America versus Europe. Now, this is one where it's kind of like saying you're looking at this group of investigators versus that group of investigators. And we said we would do this from the very beginning. So if you look at the composite endpoint here, in North America did not do as well as Europe and Asia. So the hazard ratio or the relative risk reduction here is about 49% versus about 7% here. So there's a difference. So what is it? Is it that they're smarter? Is it that they're better in terms of ablation? Is it that they have better looking kids? Is it that they have more iliac bowel and disease, or just what is it? We're just unpacking that now, but this paper will come out. Ricardo Capado will be putting this together. Actually he presented at DSC just shortly before. How about the impact of sinus rhythm? Now, in a way, this is about the only place where you can compare Cabana with the East that just came out. East looked at patients that were just treated with general methods like rate control, and they were doing that for half the patients, and then the other half of patients were treated with either ablation, 19%, or drug therapy, above 19%, basically 81%. But we can compare the impact of sinus rhythm. Now, what we did is we said, let's take sinus rhythm versus non-sinus rhythm. This was in the first grant that we wrote. And we're going to put everybody together. So patients who were ablated, patients who were treated with drugs, and we just compared those who were in sinus rhythm versus those that weren't. So you see what happened with the randomized therapy. These are just numbers, and they're identical to that first consort diagram that I showed you. And here now in drug therapy, you can see that 39% were in sinus rhythm, 61% weren't. I showed you those data from Gene Pool's study. 56% sinus rhythm in ablative therapy versus 44% in drug-treated patients. But if you look, the normal sinus rhythm patients, 961 of them, did better, 47% versus 53%. So this is absence of atrial fibrillation, and this is presence of atrial fibrillation. So let me say that again. So these are all together the patients who had atrial fibrillation. These are all together patients who are in sinus rhythm. So the confidence interval is 0.57, and the hazard ratio is 0.57, and it's 0.78 overall. So another paper that I presented at ESC is progression versus regression. So let's look at ablation, and let's look at the 470 at the beginning of the trial that went 43%, and where they went at last follow-up. Well, 67% of them went down and were in sinus rhythm. 26% still had paroxysmal. There were only 4% that progressed to persistent and only 3% that progressed to long-standing persistent. Let's look at drugs. Of the 44% who were on drugs, 49% were in sinus rhythm at the end of the trial, which was substantially less than those in normal sinus rhythm. If you look at paroxysmal, 44%, it dropped to 38%. So there's a little bit of regression. Persistence, 6%, and it dropped down to long-standing persistent in 7%. Now let's look at what that means with persistence. In persistence, 53% were in sinus rhythm at the end of the trial. 26% of drug-treated patients were in sinus rhythm at the end of the trial. Persistence dropped down to paroxysmal in 18% over the trial, but only in 9% of drug-treated patients versus ablation patients. 16%, about the same, stayed in their own category of persistent. Long-standing persistent, this is where the biggest problem was. If you looked at overall the percentage total of 100%, then there were a lot more patients on drug who by the end of the trial were in long-standing persistent atrial fibrillation. Now let's look at the numbers. AF elimination, 64% with ablation, 48% with drug. The effect size delta was 16%, highly significant. AF regression, not a lot of difference, particularly because of the persistence. AF progression, significantly higher in drug-treated patients than in ablated patients, and that was minus 6%. This minus plus is just the way that we put it on the bar graph, but it was significant. So I think what it says is it says that, you know, it actually is fairly important that we treat patients to prevent progression. And the earlier we treated them, the better they did. So now if you look at this, the primary endpoint was neutral. But if you look in patients who, you look at the atrial fibrillation recurrence, you look at quality of life, you look at minorities, you look at heart failure, you look at age, you look at AF type, you look at progression versus regression, and you look at those that were in sinus rhythm versus those that weren't, then patients who were ablated did better. Now, all of these but one were pre-specified at the beginning of the trial. The way that we did the analysis was pre-specified at the beginning of the trial. And I think what it says at the end of the day is that Cabana, for the most part, gives us a lot of positive information. In terms of adverse events, not much difference, but look down here. One person had pulmonary vein stenosis and chest pain. Nobody had an atrial esophageal fistula. And in terms of strokes, and this is one of the problems with the trial, as in terms of strokes, the stroke rate was very low. You look at TIAs down to 0.3%. You look at overall stroke risk, it was down around 6%. Over here, about the same. So the event rates were low. There were 301 patients who crossed over, and there were about 56 patients that dropped out. You know, we do have those data to the point where they dropped out. We do have the data to the point where they crossed over. That's what intention to treat gives you. And it gives you the ability to look and see if there's any change, and it maintains the benefit of randomization. Well, so does per protocol, but as treated doesn't. So what does Cabana say about ablation? Well, number one, it says that it confirms prior observational and randomized clinical trial, and we give it 5 stars. It's an effective way of eliminating AF, 5 stars. It's safe, 3 stars or 4 stars. It reduces mortality or cardiovascular hospitalization. That was with intention to treat, positive, 3 stars. And it's effective for persistent AF. That's something we didn't know before Cabana. And it blocks progression substantially better than antiarrhythmic drug therapy, 4 stars. Highly effective as first-line therapy. And the majority of patients were first-line therapy for treatment of atrial fibrillation. You know, there are a number of patients that are already on rate control, but for getting back atrial fibrillation, a large difference. So we have to put a red star by our primary endpoint and total mortality. But as we saw, there are a number of subgroups. We found out where it means something and where it doesn't. But more importantly, ablation may reduce, whether you're looking at a treatment received or per protocol, it'll reduce mortality, but especially in heart failure. So that's something that we really need to think about. So what does this do to recommendations, guidelines? What it's going to do is it's going to put persistent up to a 1B. So class of indication, level of evidence about 1B. Should it be first-line therapy? Whether you're looking at East that just came out, or you're looking at Cabana, that's going to go to a 1A. If you're looking at patients with heart failure, it's going to be someplace between a 1A and 1B. We're going to have to do Cabana heart failure to get a little bit more information, because so much of the benefit was in patients with HFpEF. And so you look at it and you say, well, you know, we would expect HFrEF, and the other trials that have looked at heart failure looked at HFrEF, but the benefit in Cabana was equally optimistic for HFpEF. And, you know, there are always issues with statistical analyses with all of these different trials where they're randomized clinical trials, and they've got problems. So we're going to do HFpEF, HFrEF, HFmrEF, and we're going to do it in patients who can be followed for a period of 2 or 3 years. And that trial will get underway not too long from now. So what should we say? Well, back in 1998, we couldn't say anything about ablation. We couldn't say anything good about it. We were just barely starting it. It's kind of like, don't get into a car with a stranger. Now, in 2008, there were a lot more patients that had undergone ablation, and we knew more about it. It's kind of like, well, don't meet people from the internet alone. But now we've changed to the point where in about 2018 with Cabana, it says a lot more about the utility of ablation. It's kind of like Uber. Order yourself a stranger from the internet and go get into a car with them alone. Well, you probably shouldn't do that. Also, this doesn't mean that you should go out and ablate every single patient that's got atrial fibrillation, because you're not going to make them live longer unless they have heart failure. unless they are under the age of 65, unless they have sinus rhythm, unless you're looking at progression, unless you're looking at quality of life, unless you're looking at the AF type. But patients with higher age and the opposite of what I just said, we're not recommending that you go out and treat them based on Cabana. What we are recommending, though, is that from a pragmatic standpoint of how we take care of patients, that there's a lot of valuable information in 2,200 patients in Cabana. And there's a lot of valuable information that kind of tells you who you should and who you shouldn't. And I think that there's a lot of positivity there. You can throw rocks at Cabana like any other clinical trial. And my point about that is go ahead, throw rocks. And as we unpack more and more data, I think that you'll see a little bit more about just what to do. So I wanted to take about a half an hour, and that's what I took, and wanted to take a look at 3 or 4 or 5 manuscripts that you haven't seen yet that bear on the issue of prognosis and bear on the issue of progression and a variety of other things, particularly in minorities and heart failure. And so I think that we have more information now that makes a lot more sense than what the tweeting twits said in the first week after the trial was released back in May of 2018. So with that, Miguel, I think I'm going to stop and turn it back to you.
Well, thank you. Thank you very much, Doug. I think, as you know, the field does owe you for completing this trial. And at a point where AFib ablation was being questioned as not having hard endpoints, and not just showing that now we do have hard endpoints, but also showing us how hard it is to complete a clinical trial. And the more ambitious you are, the harder it is. Now, you emphasize, I have 3 questions. One is technical, one mechanistic, and one about clinical trial design. You emphasize that the outcomes were good, that we can make a big impact in atrial fibrillation, the success, the freedom from AFib, much better than with drugs, but we still have 67% success. So it's not quite something to be congratulated ourselves. I mean, there's still room for improvement. And to that end, was the ablation in any way specified as far as the technical aspect? Was pulmonary vein isolation required? How much was left to the operators?
So pulmonary vein isolation and more antral isolation or wide area circumferential ablation was mandatory. You didn't have any choice.
Okay.
And then using ancillary approaches like, as you know, vein of Marshall, linear, cafe, ganglion plexi, or those sorts of things, those were up to the discretion of the investigator. And what we see there is about 60% used in ancillary something, especially in the persistence and longstanding persistence. And so they didn't have to. So, 67% isn't perfect. It's better than fire and ice.
Yeah.
It's better than most trials, and it's a larger trial than most trials. But I think the point you're making is an important one, and that is, how do we make it better? Well, I happen to have been on the DSMB of your trial, and I can't say anything about it, and neither can you until it comes out. But I think that what different trials are going to show is they're going to look at other techniques and technologies and giving us an answer about just whether that can take us from 67% in terms of freedom from recurrence and get it up to 90%. Now, you and I both know that if we went to Italy, there would be investigators now that would say the success rate's 90%. If you look at cryo first AF ablation, and if you look at the trial that I did, stop AF, then the success rate was 70%. But in 3 other cryo balloon procedures, the success rate is 83%. So I think we're getting there, but we're never going to reach 100%.
Yeah.
I don't think we should even try.
I agree. Now, the second question, mechanistically, I think it's fascinating that the earlier we intervene, the younger the patients are, the more impact we make in the natural history of AFib. And that opens a million mechanistic questions as to what it is about the pathophysiology of progression and what it is that we are doing with scar creation. After all, we're just doing crude tissue destruction. I'm just wondering what kind of trial designs we could implement to answer mechanistic questions. I don't know if you have any.
So I think we have the answers to the mechanistic questions. We just haven't unpacked them. So how you did the procedure, we don't have that out yet. But what I can tell you is younger patients have paroxysmal atrial fibrillation in whom pulmonary vein isolation works better. Older patients have comorbidities, coronary artery disease, hypertension with hypertrophy, diabetes, obstructive sleep apnea, and that increases the fibrosis and the scarring. Marouche was probably the one that's written the most on that, but there have been others that have confirmed that. And so you're looking at persistence and long-standing persistence. And keep in mind, this was a persistent trial. This was not a paroxysmal trial. Only 40% were. So mechanistically, I think it has everything to do with whether you're doing pulmonary vein isolation early, where it's a trigger-dependent patient as opposed to a substrate-dependent patient.
And finally, the clinical trial design question. We were talking about this before you started, but I find it that it's kind of self-destructive to insist by the sponsors of clinical trials on completion of a number of patients enrolled, compromising the quality of the data that goes in. And I don't, we were talking about perhaps doing more adaptive designs, being more open to interim analysis and being able to say, listen, we shot for 2,000 patients, but with the 5,500 we have now, we got good results, can we stop? I don't know if you have any ideas as to how we could do a better job without adding garbage in, garbage out to trials.
Sure. I think randomized clinical trials remain the gold standard. There, what you get is the benefit of randomization. And so I think that has to stay the gold standard. And you lose a little bit of that with an adaptive trial, and you lose a little bit of that in a trial where you do the interim analysis, and you lose it if you do Bayesian type statistics. But you can decrease the time that it takes to do a trial, and you can decrease the amount of patients that you will decrease the number of patients that you follow to the end in their group of randomization. Interim looks, you have to be careful. Interim looks are okay as long as the principal investigator and the entire team cannot see those results. If the statisticians know about that, then I think that's fair. But you cannot have your investigators looking at the interim results. Now, adaptive, you mentioned that. Adaptive, I think, is one of the newer ways of doing things, or one of the newer ways where people have kind of accepted it. Adaptive, you're going to have a change in outcomes. And so if you have a change in outcomes and you see a significant difference in those outcomes, you could adapt the patients that you're enrolling. You could also just flat out end the trial.
Yeah.
So the risk of an adaptive approach is that you're going to come to some boundary, and that boundary is going to tell you either way, end the trial, because you can't hope for getting an answer, or end the trial because you've already got your answer. Now, East did that. They didn't do as much adaptive, but what they did do is they did interim, and on their third interim look, they stopped the trial. But they also were event driven. So instead of saying we needed 2,200 patients, they said we need this many events in order for us to make a statement. And I think that those have, benefits and risks, in terms of the statistical analyses. I think that Cabana and mostly East say a lot of good information with a large number of patients, and so that's good. But you and I are not going to have the funding for doing 2,200 patient or 3,000 patient trials. A drug company could. You look at Rocket, you look at, a Pixaban trial, Aristotle, you look at Rely, and all of those had 18,000 patients. But that was looking at a question that could be answered over the course of a fairly short period of time because the event rates were so high. I think, in answer to your question, I think what we maybe could have done a better job of is selecting a patient population that had higher event rates. And then we may have gotten to where we needed. But, I don't know. We didn't do that.
So I'm going over now the questions from the audience. I can't really read this screen, but someone was asking about the primary endpoint in Cabana. And I know that the primary endpoint was changed maybe 1 year into the trial. Now, it seems, they say, okay, why the primary endpoint was chosen? It seems odd that it should include overall morbidity of recurrent AFib. I mean, you did have a very wide primary endpoint. Now I can see it, okay. The primary endpoint of Cabana was changed. Can you comment on that, on the change that was made?
Yeah. So the question's not quite right. What we did about 1/3 of the way into the trial is our primary endpoint was total mortality. The reason for that is that's what we wanted to know. If you're doing an NIH trial, or if you're doing a trial that's going to have any bearing, then, you want to know about total mortality, even if it's not the pragmatic driver of how you treat people.
Yeah.
The composite secondary was total mortality and serious bleeding and strokes and cardiac arrest. Now, a lot of people pack hospitalization into a composite endpoint. I can tell you that's the easiest way to get a trial done and the biggest way to destroy a trial. So the reason why we flipped it is because the DSMB looked at the data, and the DSMB said, you got a little bit of a problem that your event rates are lower than you thought, and you've got a little bit of a problem that it's taking longer to enroll patients, because a randomized clinical trial that's pitting ablation versus drug therapy, where a lot of people have made up their minds, that's a little bit of a problem. And so they made the recommendation, and we had not seen the data. They made the recommendation that we flip the primary and the secondary. So we did not make up a new endpoint.
Yeah.
And so we flipped it, and that's the reason why. So it wasn't quite what was suggested in the question, but we did it. And if you go back and you look at PCI trials, if you look at a very large number of clinical trials, that's done. So that is something that's an accepted statistical practice. It's something that has been done for many, many years. And out of all of the issues of Cabana, that's probably the least important.
I agree. Two more questions. Someone in the audience is asking that based on your data, we should not ablate AFib patients that are older than 75 years. Would you agree with that?
Well, so let's look at the data. That's not what I said. So what I said was, if you look at patients over the age of 75, whereas patients under 65, you're going to get a mortality benefit. If you're looking at patients over the age of 75, you're not going to get a mortality benefit. You still get freedom from recurrent atrial fibrillation. You still get quality of life. You still get it if you have heart failure. You still get it if you're an ethnic group. You still get it if you're looking at sinus rhythm. you still get it if you're looking at progression.
Yeah.
So the pragmatic question is, does a 75-year-old deserve freedom from atrial fibrillation and improvement in quality of life?
Yeah.
If you believe that, ablate them.
Yeah.
If you don't believe that, and you think that 75-year-olds should be put out to pasture, and if you believe that they don't have a right to therapy, okay, it's your choice.
One final question that I think is very interesting. I mean, they're asking in which patients do you stop anticoagulation after ablation, and I want to add more to that question, and whether you looked at the anticoagulation treatment in both groups, and if that had any effect on the outcomes.
Yeah. So the answer, and I'm gonna turn it back to you, and I'm gonna say, what do you do? But what we did from the beginning was we said we would follow the guidelines for evidence-based therapies of anticoagulants that was published in Circulation in 2006. And that we would watch as time went on how things changed or didn't change. And so from that vantage point, we required that patients with CHA2DS2-VASc scores of 2 or higher remained on anticoagulation regardless of what their outcome was with atrial fibrillation. If it was kind of a soft 2, like let's say somebody had chemical diabetes at an age of 65, and they were kind of 0 or 1s or maybe soft 2s, then we let them come off antiarrhythmic drugs. So unlike AFFIRM, we didn't see an excess morbidity and mortality because patients came off drugs. And so we think you have to follow guidelines based on that. Now, you ask about the issue of looking at the type of anticoagulation sort of thing. NOACs killed us. So since NOACs decrease the risk of stroke so dramatically, that's how you deal with stroke in atrial fibrillation. And you don't pit that against ablation because ablation can't beat a NOAC or a DOAC. And
Yeah.
so the real answer to the question is yes, we looked. And from the standpoint of total mortality, if we'd had more patients on warfarin, then this would have been a positive trial from the top to the bottom. But what do you do? What's your approach?
I go by CHA2DS2-VASc score, but it is true that the NOACs have made it much more easy to keep patients on anticoagulation. I would do extensive monitoring, and if the patient and I are convinced that there's no additional risk, no additional need or benefit from anticoagulation beyond AFib, and there is no AFib on monitors, I've stopped anticoagulation in CHA2DS2-VASc of 3.
Uh-huh.
Yeah, I stop that routinely.
That's something that bears consideration in Cabana heart failure, because there'll be a lot of patients. All of the Cabana patients in the trial, the median CHA2DS2-VASc score was 3. But I understand. My comment to everybody else in the room would be that would be something where, as long as you have a registry or a database, you're following those patients, I think we're going to find that we'll probably stop anticoagulants in more patients in the future than what we've been doing now. Jared Bunch thinks you can stop it in everybody, and I'm not quite sure about that.
No, I do think that there's a lot of patients, the vascular paths, there's other stuff going on that goes beyond the left atrium. And I think that benefits from anticoagulation too. Anyway, Doc, that was excellent, very insightful. Thank you very much. I'm glad we could make this, even it was remote, but it was excellent. And I hope to see you soon.
You too, and thanks so much for the invitation. And tell everybody in the audience to have a great day, and
I will.
Go ablate atrial fibrillation.
We will, on my way.
Or not.
All right, thank you.
Goodbye.
Take care, bye.